Welcome to Ask Dr. Geier Live, wherever you're watching. I hope you're making today your masterpiece. I am Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help you feel, look, and perform your best regardless of age or injuries. It is that time, the one place, the one time that I answer medical questions. This is your opportunity to ask questions about an orthopedic injury, a surgery, rehab, recovery, or maybe it's health and wellness, or maybe it's regenerative topics like peptides or exosomes or off-label medications like penicillin polysulfate. So I'm very excited. Please remember, I am not giving you medical advice. This is meant for general information and educational purposes only. I haven't seen you, I haven't examined you, I haven't looked at x-rays, MRIs, and I can't give medical advice online. In theory, actually, no physician or doctor or orthopedic surgeon can do that. There's some caveats to that, but in this type of setting, I can't give you medical advice. What I'm doing is giving you information that then you can use to go to your doctor, go to your orthopedic surgeon and say, hey, what about this? Give you a better understanding of what we're talking about. Or you have seen a physician, you have seen an orthopedic surgeon, and now you're trying to translate it because you didn't understand anything that he or she said. So that's the purpose of this. If you have questions you want to ask during the show, and I'll stay as long as there's questions, sometimes that's very short, sometimes that's very long, but if you want to ask a question, leave those in the chat on YouTube. I cannot see the comments, so in the chat only. If you're watching this on X, what we used to call Twitter, and I love X as far as consuming social media, but I don't know how well posting comments there comes over to Restream. I'm not actually on X. I'm on a service called Restream that allows me to send it out to Twitter, lets me send it out to YouTube, in theory Facebook, but I don't do Facebook anymore. It lets me send it out to LinkedIn and Instagram. I do this show on YouTube and X, but if I'm not answering your question on X, maybe pop over to the YouTube stream and ask it there, because I know the comments or the questions come through the chat on X. Again, very excited to be here, and I'm actually not here again, at least I don't think there's an Ask Dr. Geier Live scheduled. I get back on my last Friday of the month schedule in April I think 26th. If I can do one before then, I just have a lot going on the next couple months, but if I can do one before then, I will certainly try. But this is your chance, and like I say, I will stay as long as we have questions. All right, let's start at the top. I don't know how to say that, Nout or Newt. Should I bone fragment, Galeazzi fracture that's been removed? I'm not sure I understand the question. Should I leftover bone fragment that hurts has been removed? I'm not sure. Let me, here's another one. My doctor said leave it because there's some TFCC connected to the piece. It's from the top of my ulna where the TFC is connected. Well, again, it's hard for me to say because one, I can't see the x-rays, and two, examine you. Typically, if this is just any part of the body, if there's a piece of bone that's causing impingement on a nerve or causing pain, and it's not in an area where taking it out will cause more trouble, then yeah, it can be a reasonable thing. Those are usually fairly simple surgeries to just use x-ray guidance, take out through a small incision, take out a small piece of bone. In that case, it's hard to know because it's hard to know if it's truly attached to the TFCC. That's a cartilage complex similar to the meniscus of the knee, but on the inside, sort of the ulnar side of the wrist, there's a lot of ligaments attached to it. Yes, I guess in theory that could be where taking it out might cause more harm than good. That's really tricky without seeing the x-ray and seeing being able to examine somebody, but that would be the rationale, I suppose. Annette says, I'm on my 5th week after a tibial plateau fracture with a fibula fracture. How soon can you start rehab? Oh, first of all, I'm not going to correct or change anything your surgeon said, so definitely go by that surgeon's opinion. What I would do, I don't operate anymore now that I've pivoted to anti-aging and regenerative orthopedics, but in my 16 years of traditional orthopedic surgery, I would have people start literally 4 or 5 days after surgery. Not so much because a lot of times after a fracture repair with plates and screws of a tibial plateau fracture, you're still going to keep that person non-weight bearing anywhere from 2 weeks to 6 weeks. I mean, I've heard of up to 12 weeks, even though that seems a little excessive to me, depending on the nature of the fracture and the fixation. But you can do a lot of work to get your knee range of motion back, which I think is really important, especially getting full extension, getting it all the way flat, and then to a lesser extent getting the flexion back, the bending back, but also to work on quad strength. And early that's straight leg raising, but the physical therapy can do things like E-stem to speed that return of quad strength along. So I typically would start my patients fairly early. Maybe I was more aggressive than that, and sports medicine orthopedic surgeons are typically more aggressive with physical therapy than are the trauma surgeons, but that would be sort of how I would look at it. All right, Bambi Jacobs. How do I know if my pain is really from a frozen shoulder or if I also have some arthritis, partial rotator cuff tear, and a slap tear? It's funny, I just did a video, not on that specific question, but literally before I started this a little while ago, I did one on regenerative treatments for a rotator cuff tear, and I was talking about how one of the challenges with a variety of different shoulder injuries, when you read these MRI reports, you may see partial or full thickness rotator cuff tear, maybe a superior labral tear or slap tear, maybe AC joint arthritis, and it's really tricky sometimes to figure out which one is the source of the pain, and that matters because then you're sort of looking at, all right, which treatment do you go through? Because they can be very different, and that is tricky. There's not an easy answer to that question. Yes, an MRI can show you the problems, but what an MRI doesn't show, and x-rays don't either, is pain and where the pain is coming from. Just because you have structural damage in one or multiple areas doesn't mean it necessarily is symptomatic. And if you want to know that, look up studies on PubMed or various areas. Knee and shoulder, this has both been studied on people older than 40. They will MRI the other side than the side that is injured, and you'll see a huge percentage of patients have all these diagnoses. In the case of the knee, meniscus tear or arthritis. In the case of the shoulder, superior labral tear. and they're completely asymptomatic from it, so it can be tricky. And that's where working with the orthopedic surgeon to figure out with specific tests, if a specific test, say for AC joint arthritis, reaching across the shoulder, or superior labral tear, where you reach out and sort of across your body a little bit, thumb down, and you hold that up against resistance, which is thought to be either a superior labral tear or AC joint arthritis. Or in the case of rotator cuff, there's a variety of different tests against resistance that the orthopedic surgeon can use to clue in which of those is the source of pain. But that's really tricky. Frozen shoulder can be painful on top of all of that. That, for people that don't know what adhesive capsulitis is, it's sort of a global loss of range of motion, sometimes primary, just out of the blue, especially women in their 40s or diabetics, but can be also secondary to traumatic injuries. That can be painful regardless of what the other injuries are. A frozen shoulder, if you have a capsule that surrounds the ball and socket that's gradually getting shrunken down and that joint's tighter and tighter, any motion to the extremes of where it limits motion can be painful. So that, I wish I had an easier answer for you, but that's what I would look at if somebody was coming to my practice trying to figure out where the shoulder pain is coming from. Dennis, can a functional radiologist diagnose scoliosis? Yes, a radiologist can at least diagnose it based on x-rays, and typically you need full spine x-rays, not just any one segment, cervical or thoracic or lumbar spine, but they can at least put it in the impression, their radiologist's impression on the x-ray report, the radiology report. Typically the orthopedic surgeon, and if that's who you're seeing, reads the radiology report and looks at the studies and then does a physical exam of your back and diagnoses scoliosis. Bill says, what are your thoughts on microfragmented adipose tissue, moderate knee OA? Haven't had much success with PRP, shockwave, or hyaluronic acid injections. So a couple things. What he's talking about is and please correct me if I'm wrong, there's different ways using adipose tissue for stem cells. Ironically, just earlier, a little while ago, also recorded a video on regenerative treatments for osteoarthritis, and knee being one of the major joints. You do that for people that do fail sort of the conventional treatments, things like steroid injections or hyaluronic acid injections. I've never been super excited about hyaluronic acid injections. The studies are not terribly impressive as far as relieving pain with osteoarthritis, but it is covered by insurance, and it doesn't have some of the issues with steroid injections, cortisone injections, in terms of breaking down cartilage further and speeding up the development of arthritis and speeding the need for a knee replacement. So I'm fine with it. I just never in my career found them to be all that successful in that many patients. As far as PRP, there are good studies that show PRP can be helpful. Exosomes, I think, are going to be the next wave of treatments over the next 5 or 10 years. The early data there looks good. There's a lot of ways that people are looking at stem cells in terms of like getting bone marrow from the hip and then injecting the stem cells there. And then, as he talks about, using adipose tissue, and there's a variety of techniques and companies that do that. I always point out, and I am not promoting anything or giving medical advice on this show, but for people that are looking at regenerative options, I think it's good to look at all your options. I'm not pushing that on anybody because it is considered experimental by the FDA. The studies are very early, and it's not covered by insurance. But if people are really trying to avoid a joint replacement and want to stay active and want to try things that are considered experimental, I'm all for it. The studies, I think, are okay for fat-derived, adipose-derived stem cells. I don't think that they're game-changing, but it might be a better option than some of the other things. I'd talk to the provider, preferably an orthopedic surgeon, and see, talk about different things, talk about different ways to do stem cells, whether it's BMAC or whether it's adipose-derived. You can talk about exosomes, talk about PRP, and then kind of come to a decision that's best for you. I know I don't give a definitive answer on that, but when you're talking about things that are experimental, I don't get involved in pushing any one thing over another. I want to put information out there that then you take to your orthopedic surgeon, and the other, come to a decision that's best for you. Georgia, I did not see your messages. Let me see why I don't see it. I see this one. Give an opinion on bone broth. Does it have benefits? And if I apologize, Georgia, if it didn't come, your other questions didn't come through. So if you want to put those in the chat, I definitely will answer them because you're here very frequently, and I very much appreciate that. I hope all is well in Greece. Bone broth is thought to be a good source of collagen, and so I actually am a big fan. It gets kind of expensive, so I typically use collagen peptide powder that I put in my coffee or sometimes a protein shake, but I feel like it can be very helpful. It tends to be fairly expensive. I would try, and this is just me personally, I know a lot of people say a lot of this is nonsense, but I like well-derived bone broth from grass-fed animals and all of that kind of thing, no steroids or hormones, things like that. Having said that, the data as far as preventing any kind of issue, I don't think is really there, and there's a lot of physicians that are even skeptical of collagen, quite honestly. But it's a good source of protein. It's thought to be good for joints, thought to be good for skin potentially. So I have no issue with it. It tends to be fairly expensive. I don't do a lot of bone broth myself because, like I said, I typically put collagen peptide powder in my coffee, but that's what that is. Update on the PIP replacement. Had it on the 17th and went well. That is great to hear. 17th, so you'd be, what is that, about 3 weeks out. Fill us in on motion and all of that kind of stuff. Yeah, so that's what she's getting. Greece doesn't have occupational physical therapy. Yeah, I don't know how European countries typically do it. If the physiotherapist, that's what they're called in Europe, and I know that from my time being the chief tournament physician of a professional tennis tournament, and the physios would come over to cover the tournament, but doesn't matter. In Europe, I don't know if physiotherapists do what we consider physical therapy in the U.S., which is spine and shoulders, hips, knees, the major points, and then the occupational therapists do hands and wrists, sometimes elbows and shoulders, but typically down here, how that's done. But regardless, and I've said this, you've probably heard me say this a ton, Georgia, I'm a big fan of therapy to get range of motion back after these surgeries. Like I told somebody a little while ago about after the tibial plateau fracture, and she says it's still swollen, had a bit of motion. I think that's what that's saying. Yeah, I will tell you, the only time I did hand surgery really was in my residency, and we may have done a couple of PIP replacements, but not super commonly. But then once you go to sports medicine here in the U.S., you don't typically do hand surgery. You send those to the hand surgeons. But I don't know, quite honestly, how big of a recovery that is. I think that long-term, what you're hoping is have pain-free range of motion without the pain that you had with the arthritis, and I hope that turns out well in your case. Now it says I had a plate on a broken radius, healed very well, they said, very fast. Bone was connected, 3 months healing process, got swelling that was red. So, I guess that's potentially good. I guess what you could ask, and again, this is not medical advice, could you take the whole plate out if there's still hardware in there, and would that help alleviate pain? Typically, orthopedic surgeons, we don't take hardware out unless it's causing a problem, because sometimes taking it out, it's another surgery, and then that bone has to fill in, and if it's not needed, then you just don't do it. But that would be something that at least the next time you go could be worth asking. Georgia says her finger is pain-free now, just need the motion. Yeah, that's where the therapy would come in handy, but potentially something that you could do on your own, having them show you exercises. Shane says, impossible to get BPC for a bad injury. All I would say about BPC, and I've got videos on this, and I know for a fact, just by reading the comments to my videos whenever I talk about peptides, the people that sell it online or promote it online or get it online leave angry comments, but every expert, certainly physicians that are certified in peptide therapy, and I am one of those, feel very, very strongly that getting it online is a very bad idea. I know there's websites and they'll say third-party testing data and it looks all that professional, but the FDA has tried to inspect those companies multiple times, and tried to shut them down multiple times, and it hasn't typically gone well. Again, this is anecdotal, but I have had a patient that came to me, and from Michigan. I asked him, "Oh, how'd you get to me?" And it's because his coworker took BPC 157 that he got online and ended up in the hospital sick from contaminants in that presumed contaminants in the BPC 157. And if you read Tony Robbins' book, he has a whole chapter on peptides. He cites a study that shows that 80% of peptides sold online are fakes. There's no peptide in it. Take that for what it's worth. Pretty much everybody that does it legitimately, they recommend this. You go to a physician that does peptides, and then that physician writes you a prescription to a compounding pharmacy, a 503B FDA approved and inspected compounding pharmacy that then ships it to you. Now, there is some talk out of the FDA that they're going to start cracking down on BPC and a few others, and even making those very hard to get for reasons that I don't really want to get into here. But I think BPC can be helpful. I don't know. Here's my thing about peptides generally is I think they can be helpful for a number of things, a number of injuries. I don't think that they're the miracle cures that all of these online sites say. And again, those online sites have a financial interest in promoting them. They're either selling them or they're getting affiliate links generally. But I think they can be helpful. I don't know that they're game changers. But as part of a number of other things, and it really depends on the injury, I think there can be a role for peptides. So I know Andrew Huberman in his Huberman Lab podcast is supposed to talk about peptides soon. I'm very interested to see how he comes down on the where you get your peptides. I suspect he's going to say the same thing, even though he's a researcher, not a clinician. But pretty much every physician that I know of that's doing peptides feels very strongly about where you get them, and getting them actually legally prescribed, and not just buying whatever this is sold out of these PO boxes all over the internet. All right. Let's see. And Georgia says the finger straight. That's good. Getting it straight is really important. Now, obviously, it's bending it. Omar. Complications of, I assume MUA, meaning manipulation under anesthesia. 34-year-old male had ACL, medial lateral meniscus repair, 60 days post-op. So 60 days, let me do my math, would be, how many weeks would that be? It'd be 7 or 8, no, about a little over 8 weeks. I think it's a reasonable thing. My concern with manipulation under anesthesia after a surgery where you put in an ACL graft, and I don't know if that's truly that they put stitches in the medial and lateral meniscus or trimmed part of it out, but my concern would be you forcefully manipulate the knee, again with the patient asleep. Are you doing any damage to that meniscus repair or to the ACL? So I tend to, and a lot of sports medicine surgeons tend to err on an arthroscopic lysis adhesions where you re-scope the knee and then you can see the scar tissue and clean it out, but stay away from the ACL graft and the medial and lateral meniscus repair. But in theory, a manipulation under anesthesia, typically usually done around 6 weeks, can be done safely to try to get range of motion back. The thing I tell people, and I used to say this always, I probably did over 1,000 ACLs in my career, it's better to prevent loss of motion than to treat it once it happens. And that's where the physical therapy is so important, starting really early after the surgery. And then now it says, do I think the cause was the plate? I have no idea. That, again, I can't examine you, so I have no idea. But hardware can be painful sometimes. But whether it was in your case, that's not something an online doctor can say with no involvement in your case. One cortisone injection in my wrist for the TFCC, does it say? No, I don't know that cortisone for that type of thing is necessarily that big of a deal. I'm more talking shoulder, knee, hip, where it can definitely be shown to lead to long-term issues in terms of speeding up arthritis and things like that. Cortisone is not something you typically want around tendons and ligaments. It tends to weaken them. But doing it once, is that big of a deal? No, probably not so much. And then Shane, son just tore his calf muscle, possibly perineals, quicker recovery 18, gets back to senior year. Yeah, there is thought that BPC might be helpful for muscle recovery. mostly based on animal studies. People talk online about thymosin beta-4, TB4, TB500. There's not actually much in the way of evidence of that research-wise. Most of the studies are on BPC, but potentially could be helpful. They've never really been studied also in kids. Now 18 is essentially an adult, but that's where there's a lot of discussion about could peptides be helpful with a muscle injury. I think you could also make an argument for regenerative injections in that area, like PRP, which has been studied extensively for hamstring injuries, but calf would be a similar mechanism of injury. Yes, I'm a big fan of hyperbaric oxygen. I can't cite you the studies. We actually have a hard chamber hyperbaric oxygen therapy chamber in our office. I think it gets up to like 9 atmospheres. I just refer people to the doctors in our office that do that. I don't know really the science behind it, but I know they are very excited about hyperbaric oxygen for a number of different injuries. Georgia, you are so welcome. And now I appreciate that. You made me smarter than my doctor sometimes. The difference is, and that's going to be our last question or comment. What I will say, I appreciate that because this is why I like doing this and helping people. I know I'm not giving medical advice, but I feel like I can speak English about these injuries better than a lot of orthopedic surgeons. And I've heard that for almost 20 years now, that a lot of times orthopedic surgeons get so stuck on their technical terms and their knowledge that the patient doesn't understand. And so that's one of the reasons I really like doing this. I know it's hard because I can't examine somebody and say, hey, this is the source of your pain or this is what you should do. But hopefully you can take the information you get from me and take that to your doctors. Thank you guys so much, guys, women, men and women all over the world. I'm very, very grateful for you. Again, it may be a little while before I'm back here live, but there's going to be tons of new videos coming each week, so definitely check those out, and I very much appreciate it. Have a fantastic weekend, and I look forward to seeing you very, very soon.